Hello, everyone, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager at Clarus. We're excited to see you all here for today's live webinar, Ultrasound and Lip Fillers, a safer and more effective approach. Today, we welcome back renowned medical aesthetic expert, Dr. MJ Rowland-Warmann, to share her expert techniques to ensure safe, predictable, and beautiful lip augmentation. Dr. MJ considers ultrasound the most groundbreaking development in aesthetic medicine since the innovation of filler. And with the growing popularity of lip filler injections, using ultrasound adds that extra information about what's under the skin so you can avoid the labial arteries and plan a safer injection. You are among over 2,300 medical estheticians, plastic surgeons, nurses, physician assistants, dentists, and other clinicians who registered for today's popular event. Good morning, good day, good evening, depending on which part of the world you're joining us from. And a quick housekeeping note, please use the Q&A box at any time during today's webinar, as we'll have a live Q&A session following the presentation and live scanning, where I'm going to give you a sneak preview of an exciting upcoming addition to the Clarus app. So please stay tuned. And I'll be hosting today's event, so let's get started. So I always like to present a couple of papers on the topic before we get things underway. And it's first literature review from the Journal of Drugs in Dermatology from about a year ago discusses how even though lip filler procedures are minimally invasive, it's important to have a good understanding of lip anatomy, the muscular subcutaneous topography, and pertinent vascular structures, as well as the variability of those vascular structures. And as Dr. MJ has discussed in several past webinars, ultrasound is a very valuable tool to accurately identify all of these. In the next one, this group from Brazil noticed that filler procedures varied among professionals. Safety mechanisms such as aspiration and the use of cannulas do not always ensure total safety against vascular occlusion events caused by the filler. So they've developed a technique for safe injections using Doppler. It consists of 3 steps: arterial mapping, real-time ultrasound-guided filling, and assessing the perfusion post-injection. And finally, an update from the Journal of Cosmetic Dermatology mentions that ultrasound has not been routinely used in cosmetic dermatology due to several reasons. Some of those are large equipment, low definition imaging, costs, and availability. Now, the miniaturization and reduced costs, especially the higher frequencies like the L20 that you'll see today, provide improved quality of superficial tissue layer imaging, and this has eradicated the previously mentioned problems. The use of ultrasound leads to reduced chances of complications and clinical failures, rendering more safety and high quality. IMCAS 2024 meeting was held in Paris just last week, so I'm looking forward to what they have to say in next year's review. And just before we get underway, I'd like to just put a poll out there just to see where everybody's at as far as using ultrasound. What key benefits do you see ultrasound bringing to facial aesthetics? Do you want to have a better understanding of facial anatomy or reduce your risk of complications? I'll just give you a couple of minutes to respond to the poll. And 3, 2, 1. Good. So it looks like most people are concerned about complications and improving the safety of their injections. This is great. So you're going to find this really helpful today. All right, so without further delay, I'd like to hand things over to Dr. MJ Rowland-Warmann, founder and lead clinician at Smellworks in Liverpool. Dr. MJ shifted from general dentistry to complete her master's in orthodontics and aesthetic medicine. Today, she practices non-surgical aesthetics with a special interest in the management of dermal filler complications using ultrasound. Dr. MJ is an advocate for safer aesthetic procedures and has been widely published in industry and national media to help raise industry standards. So I will hand things over to you. Take it away, Dr. MJ.
Thank you so much. And hi, everyone. Thank you for joining me tonight. And thank you for Clarus for having me back for another webinar. We're keeping it right on topic of Valentine's Day with a session all about lips. I'm Dr. MJ, as Shelley's already introduced me. I'm a dentist, I'm based in the UK, and my practice is limited to aesthetic medicine. I've been using ultrasound for a number of years now, and I could not be without it. I use my Clarus every day for more predictable and safer outcomes and for solving complications, for which I run a dedicated weekly clinic. You guys are all here because you are smart and you are interested. And the best way to keep up with me and get free edutainment is via my Instagram, Dr. MJ Smileworks. So go ahead and give me a follow. So in this webinar, we're going to explore lip augmentation. I will show you how to scan for lip filler treatment, how to find those troublesome arteries. We're going to pick the best scanning positions, how to find filler and what that looks like, and how to fix a filler complication. The lip is difficult to image. I will show you how you streamline your assessment so you can be a better, a safer, and a happier injector. So let's get started. If you joined me for my previous webinars with Clarus, welcome back. You already know how useful ultrasound is in aesthetic medicine. If you're new to ultrasound, there are so many uses for it. You can use ultrasound before filler treatment to identify high-risk anatomy, during treatment to place filler using ultrasound guidance, after treatment to place filler to check your filler positioning. We can monitor the filler over time. We can even tell different fillers apart. And we can learn so much anatomy using it in our patients in practice. In the diagnosis and management of aesthetic complications, ultrasound is revolutionary. We can identify and resolve problems quickly and effectively. And today, I'm going to be discussing all of these applications, and you will see how ultrasound is the golden thread that runs through each case. If you're an injector, you probably treat the lips. For many, it's the staple of your practice. According to the ISAP statistics of 2022, hyaluronic acid fillers are the #2 most popular treatment for both men and women, with 4.3 million procedures performed worldwide. That's 22.9% of all non-surgical treatments. Women and some men of all ages come to get lip augmentation. So it's a huge market and it's here to stay. So why do we need to improve safety and why do we need ultrasound? Well, not a day goes by without a new story on botched lip fillers. Add to this the trend of celebrities having their fillers dissolved, and what you have is an industry that is losing trust and gaining a bad reputation. Patients are smart and they are genuinely afraid of being botched. So they're choosing practitioners based on their ability to keep them safe and deliver great results. With ultrasound, you can set yourself apart from the competition, provide more predictable treatments, and become the preferred practitioner in your area. One of the main concerns with lip fillers is avoiding complications, specifically vascular adverse events from compromise to the labial arteries. Let's review a couple of papers before we start. The first here is a lip review from back in 2019 by Samizadeh. They found that the labial arteries were submucosal in 76%, intramuscular in 21%, and subcutaneous in 1.5%. They found variable patterns of distribution, course, and diameters. And it's for this reason that they stated each injection into the lips carries a high risk. This paper was published before ultrasound really broke out in aesthetics. Compare it with this ultrasound study published hot on the other one's heels in 2020 by Cotofana. So that's barely a year later. The stats are slightly different. They found labial arteries were in the submucosal plane in 58.5%, intramuscular in 36.2%, and subcutaneous in 5.3%. So that means subcutaneous labial arteries may be as high as 1 in 20 subjects, but subcutaneous is still considered the safest plane for lip augmentation. They use the vertical transducer position seen here in the bottom right corner to gain their data. You'll be seeing a lot of this later on because it clearly shows the relationship between the labial arteries to the vermilion border. Ultrasound studies are so useful as they give us insight into the anatomy of our actual patient population. So let's put the information about arteries into perspective with regards to filler placement. And here's a cadaver study by Ganam published in 2019. They found that 58.3% of all filler injections, so almost 2/3 using needle or cannula, resulted in product placement that was close to the labial arteries. And that significantly increased the risk of vascular adverse events. Appraising techniques for lip augmentations, they concluded that the subcutaneous plane was less risky, but that vertical strands or lip tenting or Russian lips, call it what you will, increased the risk due to the proximity of the needle tip to the labial artery. Their recommendation was therefore to place filler in a different plane to the labial vessels. And realistically, the only way we can predictably keep the product away from the arteries is by scanning with our Clarus before we inject. So let's look at some lip anatomy. Starting in B mode, I use the modiolus to orientate myself because it's an easy structure to find. It's a dense mass of fibromuscular tissue formed by the junction of a number of muscles lateral to the oral commissure. On ultrasound, we can see it as a hypoechoic oval structure, and the muscles that make up the modiolus include the orbicularis oris, the levator anguli oris, the zygomaticus major, the buccinator, risorius, depressor anguli oris, depressor labii inferioris, and the platysma. The facial artery is expected lateral to the modiolus, so it's a really helpful reference point to find. Now let's first look at the lip with the transducer vertical in B mode. This is my favorite view because it gives us so much information in one go. Here's the upper lip and the lower. The orbicularis is the middle hypoechoic layer. It's sandwiched between the subcutaneous and the submucosal compartment. We can also see hyperechoic teeth in cross-section. The orbicularis is shaped like a J because it's made of two parts, the pars peripherales and the pars marginalis. The peripherales is the extrinsic portion, which is in the cutaneous lip, and the marginalis is the intrinsic portion, which forms a vermilion border. And on this histological slide, you can see both parts for reference. And as I move the transducer, we can clearly see this little round structure move side to side in the submucosal plane. This continuous, well-defined anechoic structure is a vessel, and judging by its size and location, it's likely going to be the superior labial artery. So we can see so much even in B mode. If you check out this anechoic, well-defined structure in the subcutaneous plane, that's not a vessel. It's way too big for that. Judging by its location and its presentation, this might actually be a remnant of previous HA filler. So let's now go ahead and scan the lip with the transducer horizontal. So here we've got the labial artery. It's in the submucosal plane as a long tube-like structure running beneath the orbicularis. And there do appear to be some hypoechoic deposits in the subcutaneous plane that exhibit posterior acoustic enhancement, which might be HA filler. She has had previous lip augmentations. And this is a great cross-section where you can see all the lip layers, including the skin, subcutaneous fat, pars marginalis, peripherales. We've got the submucosal fat and the teeth. So now let's look at the lower lip. On the lower lip, we can see the hyperechoic skin, the isoechoic subcutaneous fat, the orbicularis, and beneath it, the isoechoic submucosal layer. And there are some hypoechoic lobulated structures, and these are actually labial mucus glands. Don't confuse these with filler under the muscle because these are actually normal anatomical structures. And then you've also got some teeth there. We can also see an anechoic structure in the submucosal plane, and by its snaking appearance, this looks to be the inferior labial artery. So if we now go back to the vertical view and add in our color Doppler, this is the central part of the upper lip. And straight up, you can see the columellar branch of the superior labial artery as it leaves the lip and ascends towards the nose and supplies the nose tip and the septum. The vessel is superficial to the pars peripheralis, but deep to the pars marginalis. And a little bit outside that color box is an anechoic structure which looks like a vessel. And it's super close to the skin. It's less than 2 millimeters if you look at the scale on the right. So it's no surprise that filler to the philtral columns has a high complication risk. Let's check the same for the lower lip. So we can see the main branch of the labial arteries in the submucosal plane, close to the wet-dry border. There's cutaneous vessels and a branch of the inferior labial artery running between the two parts of the orbicularis. And when I'm in my busy clinic seeing patients every half an hour or so, the vertical scan is absolutely my go-to. I can quickly identify everything I need to see and make any last-minute changes to my injection techniques based on my ultrasound findings. So what I'm going to do now is I'm going to show you how to trace the labial vessels in color Doppler mode, starting with the upper lip with the transducer horizontal. So here's the modiolus, and immediately there's a vessel adjacent to it. The superior labial artery branches from the facial to supply the lip, and how it does that is variable, but generally type 3 is the most common according to the findings of Concierge from 2019. The facial artery is lateral to the modiolus, so this vessel superficial to the modiolus is likely going to be the superior labial artery after branching from the facial. And we can trace it into the lip where it takes a snaking path and ends up in the submucosal layer underneath the orbicularis. And when we tilt the transducer, we get a view of the vessel passing through that muscle there. And that happens at about 1/3 of the distance between the oral commissure and the cupid's bow. Going back to that 2020 Cotofana ultrasound study, labial arteries are found in the subcutaneous plane in around 5.3% of the population. So here's the labial artery lying underneath the orbicularis, so it's in the submucosal plane. Now, superficially, in the subcutaneous layer, there's some oval anechoic structures with posterior enhancement that we've got there. They don't exhibit flow on Doppler, so my guess is that these are HA from previous filler treatment. And we're now at the central part of the lip where the columellar branches of the superior labial artery arise before heading up towards the philtrum. And we saw those earlier on the vertical view. Gathering information with these two transducer positions gives us sort of a 3D appreciation. We've got submucosal placement along most of the upper lip with a hazard of some superficial vessels in the philtrum. Now we're going to look at the lower lip on color Doppler. From the modiolus, the inferior labial artery passes through the orbicularis to reach the submucosal plane. And there's some labial mucus glands there, which can be prominent in the lower lip. There's a number of small cutaneous branches supplying the surface tissues in the central lower lip. Interestingly, this labial artery seems to pass between the pars peripheralis and marginalis at this point. In many patients, there's a central anastomosis between the labial arteries with bilateral labial arteries in around 90% of people. That's why it's important to scan all lip quadrants prior to treatment. So the lips have 5 tissue layers. Going external to internal, we've got the skin, the subcutaneous fat, the orbicularis oris, the submucosal fat, and the oral mucosa. And with lip filler, we're aiming for the subcutaneous layer of the dry red lip, the so-called vermilion, and that's the area marked with the red line here. And that's a recommendation that was also echoed in this 2023 systematic review of lip filler complications. These chaps recommended not breaching the vermilion or the wet-dry border due to the risk of cutaneous or mucosal spread and the risk of vascular adverse events. They also made the recommendation of injecting subcutaneously with a depth of no more than 3 millimeters. Now let's get on to our treatment. I've placed a cannula into the upper lip where I would normally put my filler. And what you see here is an out of plane guided technique where the needle is perpendicular to the long axis of the transducer. And you can see it here circled at the top of the screen, close to the vermilion border in the subcutaneous plane. It's far enough away from the superior labial artery and the columella branch as well. Whether needle or cannula, this is where I want my filler to go to avoid the artery. And we must consider carefully the safety implications of using needle tenting techniques that go perpendicular to the vermilion border. This might cause vessel injury and result in vascular adverse events due to the proximity of that needle tip to the vasculature, as we already explored earlier. Because the labial arteries in this patient are submucosal, I'm actually going to use a needle for her treatment. I just wanted to show you the placement of this cannula or needle, as it were, and therefore where your filler is going to go and where that ends up on a scan. This patient is actually a dear colleague of mine, and she kindly agreed to let me place the cannula and scan her for demonstration purposes. So the information that I've gained from my ultrasound helps inform my treatment approach. For her treatment, I'm going to use a subcutaneous linear threading technique with a needle to place filler near the vermilion, as you can see circled there. It's my favorite technique for the lips, as I feel like it gives me unmatched precision. I know that the superior labial artery is in the submucosal plane at the wet-dry border in the upper lip. And here it is at the midpoint of the upper lip underneath the muscle. And we can see it again here, much the same. At the lateral part of the lip, the labial artery can be seen intramuscularly before reaching its submucosal placement. So I'm pretty comfortable with placing my filler superficially. I inject so that I'm able to see the outline, but not the color of the needle. And that's how I maintain a relatively constant depth when I'm injecting. And that's pretty much the treatment complete for the upper right. It's taking shape and there is an absence of bruising because I've kept away from the vessels. And we're now going on to the lower lip, and I maintain the same depth towards the edge of the vermilion and away from the wet-dry border. We saw earlier the inferior labial artery right there is in the submucosal plane at the central part of the lip. It courses in the submucosal plane for much of the length of the lip, so I can also be confident injecting superficially here. And I accentuate the tubercle to give more shape and more plumpness, with each strand being no more than 0.03 or 0.05. She's already got a nice lip shape, and as we know, subtle, understated lip augmentations are so much more impactful. So for completeness sake, I'm going to finish the other side as well. And in this webinar, I wanted to show you how you can recreate safe lip augmentations with straightforward pre-operative scanning to give you injection confidence, whatever your chosen technique. I don't actually usually perform lip augmentations as guided procedures with direct visualization of the cannula during treatment. The key to producing safe results is to effectively map and identify the layers and position of the labial arteries pre-operatively. This allows you to plan your treatment approach. My favorite scan is this one right here. It's the vertical transducer angulation. I scan lateral and central parts in each quadrant, and that gives me the overview I need to assess the lip. Here are my scanning locations. And assessing in cross-section allows me to determine the vessel location and the vessel depth. It's the simplest way that you can improve lip augmentation safely. So for me, if the labial artery is in the submucosal plane, I treat with a needle. If it's subcutaneous, I might choose a guided cannula approach. But given the incidence of subcutaneous labial arteries is around 5%, this is the exception rather than the norm. So with the treatment complete, let's take a look with the Clarus. We can start in B mode. This is, of course, my favorite vertical view. Here's the anechoic oval deposits in the subcutaneous layer that we placed earlier. They look like HA to me, and that is exactly where I wanted them to go. And if we now switch over to Doppler mode, there is the labial artery in both lips. The anechoic deposits are in the subcutaneous plane and they don't exhibit flow, so I'm pretty sure they're going to be HA filler. You will always notice an increase in vascularity, which is completely normal after treatment. It is trauma after all, and it will increase blood flow. So you can see how post-op imaging can reassure ourselves and our patient of a job well done. So let's move on to our next patient in this webinar. We're going to talk about how to fix one of the most common complications in aesthetics, and that is filler spread. Our patient is a 30-year-old female who's had lip augmentation in the past. She noticed that over the years, the definition of the vermilion border has been lost, so she wanted a refresh. This is by no means a terrible case of filler spread, but you can't fix filler that's not where you want it to be by adding more. You've got to dissolve it and you've got to start again. So that's our plan here. So there's a couple of ways we can deploy hyaluronidase to remove HA filler. It's either guided or it's unguided. And here's a paper by Schelke from 2022 evaluating the difference in outcomes for the management of vascular adverse events, comparing the two techniques. And the findings were conclusive. With unguided hyaluronidase, there was an improvement in clinical symptoms in 7.7% of cases, so not a lot. However, guided hyaluronidase resulted in improvement in 100% of cases. Ultrasound-guided dissolving utilizes less hyaluronidase and results in quicker improvement. So should we be using guided hyaluronidase in all of our dissolvings? Well, I think this largely depends on the nature of the complication, the distribution of the filler, and your clinical ability. In a vascular adverse event, there's usually one specific area of compromise, and targeted hyaluronidase will be more effective. In lip augmentations, filler deposits can be small, they can be spread over a large area. It may not be practical to target each deposit individually. It will require more injections, therefore more trauma, and take more time. You could just flood the area with hyaluronidase. Flooding does do a decent job, but it will use more hyaluronidase. I'm not particularly afraid of the stuff, but it is a drug, and as practitioners, we should use the lowest amount of a drug wherever possible. Flooding is imprecise, and it's unlikely to be useful if you want to target a single specific area. It can leave isolated or encapsulated deposits untreated. For anyone that attended IMCAS at the start of the month and saw the hyaluronidase talk by Sarah Koshnar, she discussed how relying on hyaluronidase to diffuse is unlikely to be effective. So you've got some clinical decisions to make here. Before we treat her, let's scan. Here's the cross-section of the lip with the epidermis and the dermis and the subcutaneous tissue, the auricularis oris, the submucosal fat, and the teeth. In the submucosal fat, there's a bunch of these oval hyperechoic structures. That's those labial mucus glands again. In the subcutaneous layer, there's some anechoic structures with posterior enhancement. They might be vessels, they might be HA. Remember, fluid-filled structures are anechoic with posterior acoustic enhancement, as little white saucer shapes deep to the structure. In the submucosal plane, there is a tube that looks like the labial artery. So let's move along a little. And the labial mucus glands are still there. We've got a few more hypoechoic structures here also in the subcutaneous plane. They're on top of the orbicularis oris muscle, and then there's a vessel appears to be lying deep to it. Now we go ahead and turn on the Doppler mode, and the labial artery you can see stands out straight away. Anything that remains anechoic or hypoechoic on Doppler in the subcutaneous plane is likely going to be filler. So let's trace the path of the labial artery from the modiolus into the lip. Here's where the superior labial artery snakes and pierces through the orbicularis to end up in the submucosal plane underneath the muscle. And here we can see an interesting phenomenon. This is hypervascularity, and it's often seen in a lip that's had lots of filler. It's where the filler causes vessels to engorge or proliferate because it irritates them. And there's many more than we would normally expect to see in a normal lip. And we see this often when we have filler. And that's also been discussed in a paper by Schelke in 2019, when they discussed a hypervascular aspect to the inferior labial artery with hypoechoic well-defined HA and multiple collateral vessels. We've always been told that HA filler is biocompatible and non-toxic, but it's actually irritant to vessels. On a microvascular level, it causes proliferation seen on ultrasound. Clinically, we see that as edema. We see patients with these puffy and swollen lips as a result of filler. It's not actually just the filler causing this, but the filler's tissue effects. So now we can go ahead and remove the filler. And removing filler, I use an in-plane technique where the transducer and the needle is in line. I select a deposit and I keep the transducer still and guide the needle to it. And I know this is HA because I've got my color box on. Once I'm at the deposit, I place a small amount of hyaluronidase, around 0.05 ml, and you can see a color flash artifact there, which occurs when there's any fluid movement. The treated area becomes hazy, and that's due to the application of hyaluronidase and a change in the properties of the injected HA. And I move quite systematically along the lip, and here's an area of considerable HA deposits and associated hypervascularity. So I go ahead and guide the needle to the target site, I deposit my hyaluronidase, and then I can move along to the next deposit and place more, saving myself multiple entry points. So you can see how treating in this way reduces the amount of hyaluronidase and effectively targets the HA.
The precision is incredible.
It's wild, isn't it?
Yeah,
yeah. This is how you effectively remove hyaluronidase, and I wholeheartedly agree with that paper by Schelke in 2019, because it is so much more precise. So you've just seen how the L20 can be integrated into the lip augmentation workflow pre, intra, and post-operatively, even to help fix lip complications. I've been doing this a while, and I've got some tips for you to get you started with your Clarus for these kinds of treatment. Practice your skills daily. Scan every patient so that you get good at recognizing the anatomy. Ultrasound is about pattern recognition. So the more times you see it, the easier it gets. Soon you'll be able to make treatment decisions from what you see on the screen, which will really make a difference to your patient's outcomes. Use standardized probe angulations. As you've seen, the vertical is my favorite. It's the best overview of the relationship between the layers and the arteries. Getting into this habit will mean your examinations are way more efficient. Scan with a purpose. Treatment appointments are tight and you do not want to waste time. Anticipate what you're looking for before reaching for your Clarus. I hear time and time again, injectors are ending up on this magical mystery tour of scanning, and before they know it, they've wasted a load of time. So plan what you want to see. Get in, get the information you need, and get on with your treatment. Use gel. And if you think you have enough gel, use some more. Lips are squishy. If you've not got enough gel, you will compress them, affecting your safety margins and your measurements. No, it's never going to be not icky. And don't give up. If you are not frustrated, you are not learning. The learning curve with ultrasound is steep but rewarding. Keep at it. Soon it will become second nature to you. You will go from someone who is apprehensive and scared of causing complications to someone who can effectively prevent them. And that, my friends, is liberating. And I know what you're thinking. You think it's going to take up loads of your time, and time is money. We've gone through the scans today really slowly and quite repetitively because I've explained them all to you in detail. In reality, the entirety of this pre-op scan for a patient takes less than 2 minutes with practice. At the Hub, we've created world-class ultrasound training so you can be a better practitioner and grow your practice. Ultrasound is complicated. I get it, it's hard. If you want to be able to do the things you've seen today, sign up to our online course. I'm completely biased, but it's also completely fabulous. Taking the course will mean you become much more confident at injecting. You will see more and possibly better patients. You will stand apart from the competition and will gain a bigger share of your local market. You will impress patients who will tell their friends. Other practitioners will refer to you even. You will be able to charge higher fees if that's what you want to do. So go ahead and scan the QR code. I'll also leave the link on the last slide for you. If you use the voucher code Clarus Webinar 3, you'll get 20% off the online course. And I want to show you something incredible now, which is brand new on the Clarus app, and that's the T mode. It's launching on February 15th. And I'm actually the first webinar showcasing it, and I'm so excited about it. It's a new tool to enhance understanding for injectors and for patients alike. It's really neat because it automatically colors in the tissues so that you can distinguish the layers much more easily. You can see here on the top two pictures, the fat and the muscle are colored in different colors. If you're new to ultrasound, this will really help you. For my patients, it's an invaluable tool to help their understanding. You can even use it with the voice commands, which makes scanning with the L20 an absolute joy. And I'm going to just give you a quick demo of us using it in practice.
Yeah. Freeze. Capture image. Unfreeze. That is cool.
That is really cool. And this is seriously advanced AI technology. It's available to you if you've got an HD3, so don't waste any time. As soon as it comes out on February 15th, make sure you try it out right away. And before we head to the demo and the questions, I want to express my gratitude to Team Clarus, who are not only streets ahead in creating devices with groundbreaking technology, but also investing so that ultrasound learning is available to all of you. And thank you to all of you out there, all over the world, showing up for yourselves, for your education, and for your patients. You guys are incredible. You are at the forefront of our field and interested in the most exciting development that has come to aesthetics in a very, very long time. I empower you all to take what you've learned tonight back to your practices and effect a positive change for safety in aesthetics. Drop me a line from where you're from, give me a follow on Instagram, and stay in touch. If you need help, if you want training, or you just want to chat about ultrasound, I love hearing from you. And we're now going to switch over to live scanning, and then it's time for a Q&A. So leave your comments in the comments box, and I will get to as many as I can.
Great. Thank you, Dr. MJ. That was amazing. So I have a model. I'm going to head over and do a live demo of what you showed us and a little bit more. Now I'm just going to load up my scanner with a lot of gel, because I remember, as my ultrasound teacher told me, you spare the gel and you spoil the scan. So lots of gel. I'm going to start here with the L20 scanner in the lip preset. And I'm going to start just kind of in the long axis view, and we'll just kind of look at the anatomy and the vascularity. So if I just start a little bit more lateral, we can see the modiolus here, this nice hypoechoic area. And then if I go to the modes menu and I turn on the color Doppler, I can move the color box over. And right away, we can see some vascular structures here.
You can even see the superior labial artery coming up over the modiolus.
Right there. There we go. Is this it here?
So that'll be the superior labial artery.
Okay, great. And then if we just move a little bit more medially, I'm on the superior labial artery here.
And here you've got your muscle.
Yeah, the orbicularis right here.
And your
the teeth
labial arteries underneath it. Can you turn on the T mode?
I will. So I'm just going to go back and I'm going to go into that view that you like so much, the vertical view, just over the lips. And again, I'm just going to put a little bit more gel, my poor model here. We've got a nice gel layer on the top. Great.
Yeah, that's perfect.
Okay, so now probably orbicularis oris here, but if we go into the modes menu again, and I turn on T mode, we're getting a nice side-by-side real-time comparison with muscle tissue here and subcutaneous tissue here in a different color. And then when I hit the freeze button, we get labels as well. So for learners, this is incredible because you're seeing side by side really good diagrammatic representation and incredibly valuable.
I think this mode is awesome because I think as a learner of ultrasound, you sometimes, that whole J shape to the orbicularis used to be a mystery to me until I saw it on ultrasound. And even looking at histological slides, it was still a mystery to me how it worked. But now that I can reconcile the transducer with the patient I have in front of me and what I see on the screen, and you can add this fabulous new mode to it, I mean, learning ultrasound has just gotten a whole load easier.
Well, and then even then, like you said, it's repetition, but now that you have kind of like an anatomy book beside you, it's just going to help that repetition even make it even more effective. So I've gone back into my color mode, and here we can see muscle here and a vessel just right over top. So that's a superior labial artery. And I just scan laterally, we can just trace that all the way back here to the facial artery. I'm going quite lateral, still seeing it here. Great, and now we're quite outside the lip here. Now the T mode also works in different parts of the face. And what I'm going to do is show you the temple. So I'll go up and change my preset to the forehead temple, and that's going to optimize our image, our depth and everything for scanning the temple. And again, if I want to identify the layers or learn what they are, I can just go back into T mode. And we're getting this real-time side-by-side image where I'm seeing bone, muscle, fat layers, fascial layers, and superficial layers. And again, if I just hit the freeze button, we actually get labels of those structures. So again, like that anatomy book type of presentation here.
That's really cool because the temple is such a complex area and the temple's got 10 layers. And reconciling that in your mind and sort of trying to take what you've learned from anatomy textbooks and recognizing it there is sometimes really difficult. So this kind of a function is really valuable.
Yeah, and I have to tell you, I mean, as an ultrasound tech, we never learned how to scan these things. So I was incredibly intimidated by the layers of the temple, and this has helped me a lot. So I can now, I know what I'm talking about, and I know what I'm seeing. I can identify it much more clearly.
I think what the beauty for me really is in patient education, when I'm scanning a patient pre-treatment or even during treatment, and I say, oh, can you see this and can you see this? The patient, out of politeness, will always say, yeah. And 9 times out of 10, they have no idea what you're talking about. But being able to show them this is just, it's priceless, because they actually then can understand what it is that you are talking to them about. And they are overwhelmingly just so impressed and so grateful that not only have you made this investment in their safety, but you're also taking the time, and you've got the apps and you've got the technology to educate them about it. And educated patients make wiser decisions. They are better patients. They refer better patients who are their friends, and your practice will grow.
Absolutely, absolutely. All right, good. We are very excited about our T-mode, and yeah, it's going to be game changing. And like I mentioned, it's going to be available February 15th, so day after tomorrow. Now, yeah, just a reminder to keep the questions coming in. And just before we open the floor to questions with our guest speaker, we'd love to help everyone continue their journey into bringing ultrasound guidance to their aesthetic practice. So please complete this poll if you'd like any additional information, and click as many options as apply. And while you complete the poll, I'd just like to take a minute to tell you a little bit more about the Clarus L20 HD3. The world's only ultra high frequency ultrasound in a 20 megahertz wireless scanner. So really good for superficial imaging. Now, miniaturization and innovation means high definition imaging is now easy and affordable, with image quality that rivals traditional systems at a fraction of the cost, representing about 85% savings. And with new Clarus Power Fan HD3, you can keep your scanner cool with a limitless power supply. So you can scan all day, or if you're doing workshops, it's not going to be an issue. With best-in-class high-definition imaging of the skin, muscles, vessels, and fascia, you'll gain confidence in your needle placement, easily characterize and evaluate fillers, and more accurately treat complications, improving patient safety and consistent treatment outcomes. The secret lies in the technology. The scanners are just like big ultrasound systems, and if you pair this miniaturized technology with artificial intelligence, like we saw, the result is crystal clear imaging without complex knobs and buttons, making ultrasound imaging fast and easy to use. Clarus is wireless, so zero footprint, fully immersible for easy cleaning, and it delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android device with free updates. Available with our new membership, Clarus Cloud allows you to easily capture and manage unlimited exams from anywhere. Your Clarus membership also includes in-app classroom videos with experts like Dr. MJ, as well as onboarding with a Clarus clinician to build up your ultrasound scanning skills. And also included with your membership, the advanced aesthetics package include AI-powered features to automate workflows like vessel depth AI, which I didn't have time to show you. And starting February 15th, as I mentioned, the T-mode AI, which I demonstrated for you today. The membership also includes aesthetic presets for the lip, temple, forehead, piriform, cheek, chin to automatically optimize your imaging parameters. So we'll take 3 seconds to close the poll. 3, 2, 1. Thanks for participating, and we will get back to you in the coming week. Now, if you didn't think T-mode was cool enough, here's a fun teaser video of what's coming on Thursday.
Welcome to the future. Got the blast off, yeah, you can call me Super. Man, I'm an icon. He lost to the clips in the game like my middle name is Luna. Up in the cruiser, we'll be taking off. Now you heard the rumors. Yes, I got the sauce. A true needle mover. I never took a loss in this game. I'm the ruler. Yes, I am the boss. Nothing's gonna be the same. Nothing's gonna be the same. Nothing's gonna be the same. Everything's about to change.
All right, and one more quick poll before we get to your questions. We have a webinar coming at the end of April with guest speaker, Dr. Zainab El-Mukhtar. And this is your chance to pre-register. She is an expert non-surgical rhinoplasty, and she'll be presenting her skilled use of ultrasound for procedure planning. So let's get to your questions. I want to let you know that a recording of today's session, as well as a PDF copy of the slides, will be mailed to you in the coming days. All right, so
oh my gosh, there's so many questions.
I know. All of a sudden they were just
type like a little wizard in the background and try and answer them already.
All right. Well, let's see.
Lots of questions on T-mode.
Exactly. Yes. Okay. Here's a question. Almost everybody asks: is what needle size do you use for dissolving HA filler?
So for dissolving HA filler, I use a 27 gauge 3/4 of an inch, which is yay long. I find it can reach most of the way underneath the probe, but you do have to put your HA deposit on the left-hand side of the screen to be able to reach it with your needle. For precision, I find needles better than cannulas for dissolving. I never use a cannula for dissolving. That's just my personal preference.
Okay. Do you have any comments on the effects of numbing creams on the lips during ultrasound-guided injections and dissolving?
So I am a dentist, so I love my patients to be numb. I generally use injected local anesthetic, so I will use a buccal infiltration for most lip augmentations, and that patient was numb as well. And I will use a buccal infiltration for dissolving as well. There's both the first and second patient were numb. Now, what you will find if you have applied local anesthetic is there will be a slight increase in vascularity, because the effects of lidocaine are one of vasodilation. So you will see a little bit of increased vascularity as a result of applying lidocaine or injected lidocaine to the tissue.
All right. Kind of a similar question. Did you specify which type of needles you use to visualize on ultrasound?
I always say, for people who are learning, the fatter the better. So if you're starting off with guided filler injections, start with a 22 gauge cannula. Don't make your life hard. Start with something that's non-flexible and where you can visualize your cannula quite easily. A 22 gauge is great. For guided dissolving, you can get away with a 27, you can get away with a 25 gauge needle. I prefer needles because, again, they're non-flexible. A 25 gauge cannula for me is too bendy and too flexy. So I personally don't use them for guided dissolving.
And I'll just add a little bit to that too. When you're doing injections, and this applies to any application, not just aesthetics, but when you are injecting the needle and it's the sound beam is going in like this, and you're injecting like this, and your needle is perpendicular to the sound beam or in line with the scanner plane, that's going to be the best visualization of your needle, no matter what size it is. It's when you start going a little bit steeper that the sound beam isn't kind of impacting that needle at 90 degrees, and you're going to get some refraction artifact. So when in aesthetics, you have the luxury of being quite superficial and coming in at different angles to keep that needle kind of perpendicular to the sound beam. So that's just kind of a little tip to help you out with that. Okay. Yeah, lots of T-mode questions. You see any questions?
Here's a good one. Would you charge more for the use of ultrasound? That's actually a matter for you. Personally, I didn't. I already find that my fees are commensurate with the work that I do. I am maybe a little bit more expensive than other providers in my area. With practice, I didn't actually need to increase my appointment times. So my fees didn't have to increase because I wasn't spending more time. So the key is not to think, how am I going to make up for this shortfall of time? It's just practice until it seamlessly integrates into your workflow.
Great. There was a question about patient positioning to scan the lips.
Yes, what do you ask the patient to do? Generally, I get the patient to just close their mouth, because ultrasound gel in the mouth is really icky. So, so I get them to just rest and close their mouth, don't pout, don't anything, and then I will scan them in the six, or the two sections of the lip in either quadrant. So in the very lateral parts, in the medial parts, but either side, and in the lateral parts.
All right. One question, I think have you used it for an occlusion? I assume they're asking about ultrasound.
I have used it for many occlusions.
Yes, that's your specialty.
Yeah, we actually had an ultrasound course at the weekend where a vascular adverse event rocked up. So that was pretty exciting. And what you generally tend to see with vascular adverse events, I would say use the power Doppler mode because it assesses the speed of flow rather than color Doppler, which does the direction of flow. With an occlusion, you're less interested in the direction of where the flow is going and more interested in the speed of the flow. And power Doppler can pick up lower flow of blood. So what you will generally see is an area where the perforated vessels that usually come up from the source artery are interrupted, or an area that is very quiet. You may also see areas of stenosis if it's an intravascular occlusion, but yes, you can see these things with a Clarus with some practice. What I would, however, recommend is when you get your brand new Clarus, focus on normal anatomy and preoperative scanning and reducing your incidence of complications, because that's where the real gains are made as an injector who's new to ultrasound. Rome wasn't built in a day, but it was built. And with time, you will be able to handle more difficult cases, assess unusual or atypical anatomy, even complications.
Yeah, and just practice, and the more comfortable you become with recognizing the anatomy and seeing how deep the vessels are, the easier it gets. It's like anything.
Absolutely.
When you see hypervascularity in the subcutaneous submucosal plane of the lip, the target plane we usually inject in, and sometimes it's really dense in arteries, is it not better to use a cannula instead of a needle to avoid bruising and microocclusions?
Listen, if you're going to dissolve, you're going to bruise them anyway. So you warn your patient that they're going to bruise, and then you target the areas that you want to target. If there's a lot of hypervascularity, you've got to ask yourself the question, why is that there and what is it doing? So if you've already got a huge amount of hypervascularity going on, do you really want to be putting more filler into that? That should get you thinking of, is that hypervascularity actually causing a clinical edema? And how much of what I see is real? And how much is that due to the microvascular effects of the filler on the vasculature? So it should really get you thinking. What you're seeing on ultrasound should get you thinking about what the tissue effects are, and then what your plan of action is. Just because you've got hypervascularity doesn't mean you should always just treat on top of that. The answer to that is often, do I want to take that filler out, let the tissue recover, and then start again?
All right. Well, I think we'll call it a day at that. We've reached the top of the hour. Now, if we didn't get to your question, we'll follow up with you by email in the coming week. And a friendly reminder again that you'll receive a copy of the slides in the webinar recording. So keep an eye on your inbox, and please complete our closing survey to provide your feedback so that we can bring you more educational webinars like today's. And to conclude, I'd like to thank you, Dr. MJ, for your enthusiastic insights, and a very big thank you to all of you for joining us. Have a wonderful day, keep scanning, and happy day before Valentine's Day.
Thank you so much. Happy Valentine's Day. I hope you all have a Clarus to kiss tomorrow.
Bye now.